I'm Dr. Sohail Chaudhary. I'm one of the interventional cardiologists with the Secours Richmond Cardiology Associates. I practice out of Memorial Regional Medical Center here in Mechanicsville, Virginia.
Hi, my name's Samir Rohatki. I'm one of the interventional cardiologists with Virginia Cardiovascular Specialists based in Mechanicsville, Virginia.
Hi, my name is Brody Wayman. I'm one of the cardiothoracic surgeons here.
Hi, my name is Renee Tierney. I'm a nurse practitioner with the Structural Heart Program here at Memorial Regional Medical Center.
So the problem we're going to talk about today is aortic stenosis. The heart is a pump. It circulates blood throughout the body. The valve in particular that we're going to talk about is the aortic valve, and it should open fully and close fully. In some patients, over time, their valve doesn't open completely, and that's called aortic stenosis.
The signs of aortic stenosis for your patients varies. Fatigue is usually one of their first signs. We also see people with palpitations, shortness of breath with exertion we see quite often, and people don't really notice it as much as their spouses notice it. People who have chest tightness, and then kind of down the road they have some leg edema, they can be lightheaded, and then you'll see people who actually have syncope, and that should be in your mind with somebody who presents that way with that history of AS.
It affects primarily elderly patient population. I would say more common in patients who are 70 and especially 80 and above. There is a type of aortic heart valve condition where heart leaflets are what we call a bicuspid, or there are two leaflets. In that case, young patients who are in their 60s and 70s can also present with this condition of aortic stenosis.
Once you find that the patient has severe AS, and that's usually defined by a peak velocity greater than 4, but certainly when you get into 5, a high mean gradient over 40, and a valve area that is less than 1, their risk of sudden death in 2 years is quite high. So it's super important that when your patient has moderate stenosis that you get them into the network and get them treated. We no longer wait until patients are quite symptomatic. We instead work on people before then, so that we can get them before their ejection fraction or their muscle starts to get weak, because we want them to have a good outcome.
Generally speaking, valvular heart conditions, especially aortic stenosis, we can, in the earlier stages, we can manage them with medication. But more or less, you have to treat this with condition ultimately by replacing a new valve. There is no medicine that can reverse the process or treat the underlying valve deterioration that we can say can make it stable or reverse it.
The workup initially is an echocardiogram, which is an ultrasound of the heart where we can look at the heart function and we can measure the severity of the stenosis in the aortic valve. Following that, there are several tests once we determine that the valve is indeed severe. Often it includes a CT scan, which looks at the aorta, or the big pipe that comes out of the heart, as well as a cardiac catheterization to make sure there's no blockages in the arteries of the heart, an ultrasound of the carotid arteries to make sure people don't have blockages there as well. So once we determine that the valve is indeed severe and it needs to be treated, there's two typical ways of treating the valve. One is called surgical aortic valve replacement, and that's what people mostly think of when they think about treatment for aortic valves. And that requires a sternotomy. The surgeon is able to visualize the valve, cut out the valve, and sew in directly a new valve. Over the last number of years, there's a new technique called TAVR, which stands for transcatheter aortic valve replacement, where we're actually able to deliver the valve through catheters, often through the femoral artery near the leg, up to the heart, position it, deploy a new valve, pushing the old valve aside.
In addition to, not only it has made it make it easier for patient, because this can be done safely and with a minimal approach, now we can offer this treatment to a lot of those patients who historically we couldn't help them because they were too risky to undergo any kind of open heart surgery or major surgical procedure, be it because of their age or their associated medical condition, or if they have advanced emphysema, and things like that.
In the event that they're high risk or they're low risk, but with certain features that make them more amenable to a TAVR, we evaluate those patients comprehensively and we bring them to the cath lab here at Memorial Regional. At that time, both me and the cardiologist work together to perform the actual TAVR procedure. We're both scrubbed in at the same time, and my entire heart surgery team, my OR team, and the perfusionist are available and on standby in case any emergency happens.
TAVR itself is a valve where we stick your groin, your femoral artery usually. We have some other options as well if you have some peripheral vascular disease that we're not able to do that particular approach. And we basically take a valve and we crimp it down, we make it very small, and we put it inside a sheath. That sheath varies in size, but it's like having a cardiac catheterization. We take that valve, we put it up through your femoral artery and up through your aorta. We actually cross over the diseased valve. That calcification that's in the valve is actually what helps the TAVR valve to stick. The TAVR valve is a wire caging. It has porcine tissue in it, and it's the valves themselves. And so what it does essentially is becomes a new valve. It sticks to that old calcium that's causing the patient to have a narrowed valve area, and by doing that, the patient has an immediate relief of symptoms. So that valve opens up with a balloon, and once it's open, those valves then open and close like they did when they were younger. We don't get them back to exactly where they were, but we can usually double the size of the area that they had ahead of time. And then once we do that, we take the catheter out, and the patient basically usually feels better and is able to go home the next day.
At the conclusion of the procedure, we work together as a heart team to take care of the patients and get them discharged home in a timely manner. And if it's not home, then to a rehab facility in the most efficient way possible.
There are several advantages that the patient can have from doing it this way rather than a traditional surgical procedure. Through TAVR, there's smaller incisions are typically on both sides of the legs. The procedure itself can take anywhere from 1 to 2 hours, and people can go home within a day or two with really a recovery of only a week or two before they feel all the benefits of the valve replacement.
That's the beauty of transcatheter aortic valve procedure, is the recovery is very quick. So we do these patients in the morning, and by afternoon patients are sitting in their chair, and we make sure that they are walking in the evening. And our patients go home next day. That's as far as recovery is concerned, because procedure is done through a small tube in a groin, and there is after the procedure there is no stitches, no incision that needs to be healed, so there is no pain afterwards. You may have a little bit of a bruise or tingling of numbness or swelling in the right groin area, and we watch for it, but that's about it. As far as we overnight monitor patients that make sure that they do not need any pacemaker and their valve is functioning okay. We get an ultrasound next morning before we leave the hospital, and we just make sure the valve function is okay, and that's about it.
This would compare to a surgical procedure, which often takes up to 3 months before they start to feel better from the valve replacement.
After the TAVR procedure, we see the patients back in my clinic. I follow up with them at 1 week and then at 1 month, and so does the cardiology team. So they're under our care for the early post-operative period to make sure that there's no issues with the valve, no issues with their groin, or any issues with the rhythm. It truly is a multidisciplinary process between myself, the interventional cardiology team, Renee Tierney, our nurse practitioner, a valve coordinator, and the entire the nursing staff as well. And again, again, so far things have gone really well, and we're looking forward to continued growth and continued success.